as you know that we have studied the inflammation, acute inflammation, earlier, and today's topic is a clinical topic of pneumonia, and today's and the next topic, the CBL, they are linked to each other, but the main basis lies in the acute inflammation. If you remember when I taught you the inflammation, I showed you two pictures together of lung tissue, in which one, the alveoli were filled with the neutrophils. Which type of inflammation was that?
Acute.
Acute, because they were
Neutrophil.
neutrophils. And the other one, there was a round lesion containing macrophages and lymphocytes. So what was that?
Chronic.
Chronic inflammation. That acute inflammation in the lung tissue with the neutrophils were because of the infection with certain microorganisms we discussed today is your pneumonia. So, pneumonia is the inflammation of the lung parenchyma resulting in consolidation. So there is an infection that reaches the alveoli, the lungs, then it incites inflammation, and as a result of that inflammation, there is consolidation. Consolidation is called solidification. We discussed that in a separate slide. So you tell me, in an alveolus, if there is air, or in the alveolus, if there is liquid, which is more solid?
More solid liquid.
Is the one where there is a liquid. So that's why when you have an accumulation of liquid in the alveoli, this is called consolidation. And what causes consolidation? Inflammation of the lung tissue. And how the consolidation occurs? Because of the excessive exudate formation. So this exudate is formed from where? Where is this exudate coming from? Yes. Where does the exudate come from?
From the blood vessels.
Not from the lung tissue, it goes into the lung tissue.
Blood vessels.
From the capillaries of the alveolar walls. So once there is inflammation, there will be increased vascular permeability of those capillaries and the fluid is going to go out. And where is it going now? Into the intra-alveolar space, within the alveoli. So this is your pneumonia. So again, the same sequence we told you, there is always a stressor that causes the injury to the cell, and that cell injury incites the inflammation, which is the response of the vascularized tissue. So in this case, the microorganisms that cause pneumonia are the stressors. The injury that takes place is in the alveolar walls, and the inflammation is acute inflammation that occurs in response to it, that leads to the exudate formation in the air spaces, leading to pneumonia. Now, pneumonia can result when our body's defense mechanisms are impaired. So, there are so many microorganisms around us. Do we get pneumonia all the time?
No.
No. Maybe sometimes, but not all the time. Because we have strong defense mechanisms. Those people who have weak defense mechanisms, impaired defense mechanisms, they are at high risk of developing pneumonia. Those with chronic diseases, those who are having diabetes, who are having autoimmune diseases, those who are having the chronic kidney disease. So all those with the chronic diseases, they are at higher risk. Then those with immunological deficiency, whether it is to do with AIDS, if someone has AIDS, human immunodeficiency virus, so the immune system is deficient, or there is immunosuppressive status that the person's immune system is okay, perfect, but we are keeping it suppressed intentionally in order to treat an autoimmune disease like SLE or rheumatoid arthritis or whatever. So what we do, we put the brakes on the immune system so that the autoimmune disease does not flare up, but it makes you at more risk of developing pneumonia. So these people with chronic diseases who have immunological deficiency and who have immunosuppressive status, these are the people who get the vaccine for the pneumonia regularly. Each pneumonia vaccine can last for 4 years. And that is the reason when COVID came and the vaccine came into the market, it was first given to people who had chronic diseases with immunological deficiency or those which were on immunosuppressive therapy. You have a point? So these are the people who are at high risk of developing pneumonia. So in order to develop pneumonia, the first thing is that the microorganism should enter the respiratory tract. Then it should replicate and spread. And finally, once the microorganism reaches the lung, it's not there for vacation. It's there for some purpose. And the purpose is to damage the lung tissue. So it will lead to the tissue damage. So these are the 3 steps. So how does a microorganism enter into the respiratory tract? This is the first question. The first way is aspiration, to aspirate. Whenever the gastric contents, they move up and they can enter into the respiratory tract, then it is called aspiration. In a normal human being who is a strong human being, anything that tries to enter the respiratory tract, he had a very strong cough reflex to push it up and throw it out, so it does not reach the lung. But in people who are chronic diseases, who are old in age, who are weak, what happens is that if they have severe vomiting sometimes, that vomitus can enter into the respiratory tract and reach the lung tissue. So this is one way, and one of the most common microorganisms that can enter the lungs through aspiration is your pneumococcus. What is the name of the pneumococcus in microbiology? You study microbiology? Yeah? Streptococcus pneumoniae, very good, yes.
Can you explain it again, the aspiration?
Yeah, don't worry. We have all these we will discuss in each slide. So when I reach there, if you do not understand that, I will repeat again. Okay? This is just to inform now, and then we discuss every one of them onwards. Okay. Then is the inhalation. You know, it is around you and you inhale it. For example, TB. How does the TB spread? In a household, usually TB is common in the poor countries where a lot of people live in a very tight environment. One room shared by 5, 6 siblings. One of them get a TB. He's throwing out the TB bacteria, Mycobacterium tuberculosis, and you can inhale it. And that can lead to a chronic pneumonia. Inoculation, contaminated equipment. I'm using this equipment. If this is contaminated with a microorganism that can cause pneumonia, I am using it and then I put it close to my nose or my mouth so I can take those microorganisms into my respiratory tract. Colonization. Patient with chronic obstructive pulmonary disease, COPD, is very common in the smokers. There are two diseases, emphysema and chronic bronchitis, which are very common with smokers. But what you need to know here is not the COPD disease itself, but remember, COPD leads to some damage in the respiratory tract, which makes a form kind of cavities, and then a microorganism, if it reaches there, it can form a colony there, and that colony can then spread from the remaining respiratory tract into the lungs. Hematogenous spread, sepsis. What is sepsis? Yeah, infection where? Yes, when the microorganism reaches the blood. For example, I developed pharyngitis because of infections of Streptococcus pneumoniae in my throat. Now, if I don't get it treated in time, I don't go to the doctor in time, I don't get antibiotics in time, and the infection flares up, it spreads so much that it enters into the blood. This is the most risky time because this can even lead to death. So, if there is the Streptococcus pneumoniae in the blood, this blood will reach the lungs, and from there the strep pneumonia can enter into the lungs and can cause pneumonia. Finally is the direct spread. Any abscess, abscess, the localized collection of the pus that contains exudate, neutrophils, dead necrotic tissue, as well as the microorganisms, that from that abscess, if it is very close to the lung, then the infection can spread into the alveoli and can cause pneumonia. Then, whenever any foreign object comes into our respiratory tract or any microorganism, normally we have two types of defense mechanisms, the mechanical and the cellular. The mechanical defense mechanism, the first defense mechanism is your coughing. So when we cough, we take that thing out. The other is your mucociliary transport, mucus. Whenever a microorganism goes in, usually it attaches to the mucus, and the mucus then has the cilia. The cilia push that mucus up, 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 up. If the mucus is big, then we throw it out. I need to go to the toilet to throw it out, isn't it? If it is small, we don't even realize it comes up the larynx, enter into the food pipe, the esophagus. From the pharynx, from the oral cavity, it goes into the esophagus. We don't even feel that. This is your mucociliary transport. That's why in smokers, because of that metaplasia, the cilia isn't there, so they are more prone to infections than non-smokers because that mucociliary transport is not working in them. Then is the cellular. Remember I told you, macrophages are present in different tissues of our body just for protection, not necessarily that it is inflammation. Without inflammation, they are present in the brain, in the liver, in the lungs. They are called alveolar macrophages. So they provide a normal defense mechanism. But these two things, when they are impaired or weak, that is where the pneumonia happens. And where they become weak, the one of them is that the person is immunocompromised, the white cells are not working well, or the organism is highly virulent. Virulence, we will discuss that onwards in the CBL. Virulence means the ability of a microorganism to make damage, to cause damage. How lethal that microorganism is, how damaging that microorganism is. So if it is a very highly virulent organism, then these defense mechanisms are going to be impaired. Then these organisms, when they escape these defense mechanisms, they reach the lung tissue, and there they cause the damage to the tissue, and the damage to the tissue is caused basically by the toxins these microorganisms produce. These toxins, cellular toxins, they cause direct damage to the tissue, as well as they have an impact on the neutrophils, and they decrease their ability to kill. Number of organisms is very critical. You tell me, if someone inhales, even if he has a defense mechanism impaired, someone inhales small number of microorganisms and someone inhales large number of microorganisms, which one has a higher probability of developing pneumonia?
Higher.
One who has a lots of microorganisms. So the number of microorganisms is very critical in determining the disease intensity or happening of the disease. And then is the tissue damage. The damage is directly caused by the cytopathic effects of the microorganism, that it produces the toxins. And then the inflammatory response. Remember the leukocyte-induced tissue injury? If the acute inflammatory response is very severe, it can lead to the tissue damage. And if it becomes the chronic inflammation, like in chronic pneumonia caused by tuberculosis, then you know that the chronic inflammation is associated with every day there is inflammation, there is tissue injury, and there is repair going on. So that is the other cause of the tissue damage. Now we classify the pneumonias. Community-acquired acute pneumonia. An acute pneumonia, which is an acute inflammation of the lung, that we acquire the microorganisms from the community. This is called community-acquired acute or typical pneumonia. There is another one, a community-acquired atypical pneumonia. Then you have nosocomial pneumonia. Nosocomial means hospital-acquired. A person came to the hospital for a surgery. The surgery, he didn't have any pneumonia. The surgery got complicated. He has to stay in the hospital for the whole 1 month. During his stay in the hospital, when he developed the pneumonia, and this is called nosocomial pneumonia. Then aspiration pneumonia, as I just told you, when you aspirate the gastric contents into the respiratory tract, then it is called aspiration pneumonia. Chronic pneumonia is associated with chronic granulomatous inflammation. And which microorganism can cause chronic granulomatous inflammation? TB is not a microorganism. TB is a disease, tuberculosis. Mycobacterium tuberculosis. You have done the microbiology. You should be knowing these names by now. Necrotizing pneumonia, lung abscess. When there is a severe necrosis in the lung tissue leading to the lung abscess, then the pneumonia is called necrotizing pneumonia. And then there is a special pneumonia that occurs in the immunocompromised people. Immunocompromised people are at risk of developing pneumonia, but from certain specific microorganisms, and this is called the pneumonia in the immunocompromised. So we're going to do all of them today. Yes?
When you said the mechanism of defense, you said the cough reflex.
Yes.
Can it be like, for example, I coughed it off someone?
Yes, definitely. When you cough it up, when you cough, that's why they say put your hand in front of it. Put your shoulder in front of it, because if you cough, you're sick. With these microorganisms, you can throw those microorganisms in the air, and the other people, when they inhale, they can get infected.
But if I cough with my hand, can I not get it back?
No, I mean, you already have it. It's not the matter of getting it back. You already have it there. If you are cuffing it in your hand, you have plenty of microorganisms inside you. You don't need to get them back. The main problem here is you giving it to the other people. Okay. Now we talk about community-acquired acute pneumonia, a typical pneumonia. It's also called acute bacterial pneumonia. It is of two types, lobar pneumonia and bronchopneumonia. When the consolidation involves the full lobe, it's confluent in distribution. Confluent means it's spread. The whole one lobe has consolidation which is filling the full lobe. Then that is called lobar pneumonia. And if the consolidation is in the form of patches, small patches, then it is called bronchopneumonia. These patches are the consolidation or the liquid around the bronchioles. We will talk about the both of them in the coming slide. So remember, which one of the two will have the entire lobe consolidated? Lobar, remember the name, lobar. And where you have the patchy consolidation is the bronchopneumonia, remember that, from the bronchioles. At the end of the bronchioles, there is consolidation. Now, remember one thing, the most common organism that causes the acute bacterial pneumonia is Streptococcus pneumoniae. Streptococcus pneumoniae can cause both lobar and bronchopneumonia, but most of common of that type is the lobar pneumonia. So classically, this microorganism, which is the most common microorganism that causes acute bacterial pneumonia, it causes which type? Lobar type, where the entire lobe has consolidation. But of course, it can also cause bronchopneumonia. But which one is the most common type caused by Streptococcus pneumoniae? The lobar pneumonia. Very good. So, consolidation, as I told you, is solidification. Alveoli are filled with inflammatory exudate due to bacterial invasion. So there is bacterial invasion in the alveoli that has triggered to the inflammatory response. The alveolar capillaries which line the alveoli to get the oxygen and give the carbon dioxide back, they become permeable. A lot of fluid enters into the alveolar space, and this is called your solidification or consolidation. So there is fluid in the air spaces. Where does it come from? It's actually an exudate. Why is the exudate from? Because of the inflammation in the lung tissue. Why there is inflammation? Because there is a bacterial infection. Clear? So this is the sequence. Now look at that. Which one of the two you think is the lobar? Left? This is lobar? This one. See, the entire lobe is consolidated. Can you see this? Entire lobe has consolidation, and look at that. Do you see the patches? This is bronchopneumonia. This is your lobar pneumonia. Have a look at this. Whenever there is consolidation, the lobe will appear pale. Remember that. In the lung, the lobe will appear pale when you look at the lung tissue. Can you see the entire lobe? So which one is this? Lobar pneumonia. And can you see these white patches? This is the bronchopneumonia because the entire lobe is not involved. There are patches of consolidation. Have a look at this X-ray. Tell me, which one is the lobar?
On the left.
One on the left. You see here? This is the right lung, this is the left lung. The right lower lobe is filled with consolidation in an X-ray. Air, which is less dense, it appears black. Very good. So this is air inside the lung. And anything which is more dense, like the bones, can you see the clavicles, the ribs, the sternum, the vertebrae? So anything which is more dense, it appears white. So now, if the lung is filled with an exudate, will it appear white or black? White, because it is denser than air. So you look at this white thing here. And these white things, sometimes the student asks me, oh, what is this? Is also some concern. No, the lungs finish here. This is an X-ray from a female. It's the breast tissue. Breast is denser, so it comes in X-ray as white opacity. Okay? No, diaphragm will not come here as, because diaphragm is like is a dome-like muscle which is like, inside it, so you cannot really see that on the X-ray. Okay, so, and you see here, the patchy consolidation, the lung fields are present, there is air in it, but there is patches of consolidation. So this is your bronchopneumonia. Now, we focus on lobar pneumonia, the most common type of acute bacterial pneumonia caused by Streptococcus pneumoniae. What happens in the lung tissue when it is having lobar pneumonia? The entire lobe is involved, which is having consolidation. So the first step is congestion. The blood vessels, alveolar blood vessels, they dilate. The first step of the inflammation, vasodilation. Now the bacteria has reached the lungs. There is the first step, inflammation has started. The first step will be vasodilatation. The vasodilatation, what will it cause? It will cause a lot of blood to come into the alveolar blood vessels. So there is engorgement. Engorgement means when there is accumulation of a lot of the oxygenated blood. So there is engorgement of the blood alveolar vessels. Have a look at this. And this is also called congestion. This is an alveolar space. This is an alveolar space. Can you see the capillaries which are lining the alveolar space? The red ones are your red cells. These are the red blood cells present in the capillaries which surround the alveoli. Now they are filled with a lot of RBCs containing the oxygenated oxygen. So there is a lot of oxygenated blood, and what's the reason for that? Is the vasodilatation. Okay? This is the first step, the congestion. Next step, red hepatization. Hepato means liver. Hepatization means something looking like liver. So there are cells which the alveoli, they are filled with so many cells that they look like liver. If you have studied the histology of liver, or I will show you the structure of liver when we study that tissue repair, there are lots of cells in the liver in the form of sheets, loads of cells. So here, the alveoli are filled with so many inflammatory cells that it gives like an appearance of a liver, and because there are red cells there as well, red blood cells, so it is called red hepatization. Have a look at this. Can you see filled with the inflammatory cells, isn't it? Looks like the one which I showed you earlier on the right hand side with the neutrophils. Look at this now with more, we focused it. This one, one alveolus, we magnified the microscope. Have a look at this. This is your alveolar blood vessels, isn't it? The red blood vessels. There you have first vasodilatation. Then what is the next step in the inflammation after vasodilatation? Yeah? You're not, yes, I say it again. Increase permeability. So when the permeability increases, what enters into the alveoli? Exudate, isn't it? There will be margination, rolling, adhesion, pavementing, transmigration, and the white cells will reach here, isn't it? Because that's where the bacteria has reached. So see a lot of neutrophils filling the alveolus. But as the permeability increases, you see the red blood cells also enter into the alveoli. Can you see those? They are not just in the alveolar blood vessels, they have also entered within the alveoli. This is called, that's why it's called red hepatization. The next step is your gray hepatization. Now, when the white cells, yes, you have a question? You have a question? Okay. Now when this one here, you tell me. So all these neutrophils which are here, what is going to be their function here? To kill the microorganism, isn't it? They become activated, they will try to kill the microorganism. Any damage to the alveolus that has been caused, it is going to be, the dead cells are going to be digested by them. So obviously when they become activated, they will also kill these red blood cells, isn't it? So when these red blood cells are phagocytosed by these neutrophils or macrophages will come later on, what will be released from these red blood cells? Very good. This will be converted to hemoglobin first converts to something else. Hemosiderin. Remember I told you hemosiderin laden macrophage is characteristic of hemorrhagic inflammation, isn't it? So now what happens? These cells, they kill the red blood cells. From with them and comes out hemoglobin, which gets converted to hemosiderin, and this is called gray hepatization. The same alveolus with a lot of cells in it. Now the cells are containing, these are cells. What are they containing? What is this grayish or brownish pigment? Biliverdin, not pus. Pus is white. Here, the fluid is white.
Want the neutrophil release pus from the
Neutrophil don't release pus. You maybe then you don't understand the pus. What is pus? Pus is an exudate. It's a fluid that contains proteins. Exudate, fluid with proteins. It contains in it neutrophils and also dead necrotic tissue and microorganisms. Pus is not produced by the neutrophils. Pus comes from the increased vascular permeability. Pus is an exudate. So these ones are actually the cells, the macrophages or the neutrophils. And what is inside them? Because they phagocytose the red blood cells, so they have the hemoglobin, which is converted to the hemosiderin, and now this is the hemosiderin present here. And that state where you see these hemosiderin-laden inflammatory cells in the alveolus is called gray hepatization. So red hepatization, a lot of inflammatory cells, exudate, and red blood cells. In the gray hepatization, the neutrophils are going to destroy the red blood cells, and then they are going to kill it. Okay. Now, mark your attendance, guys. Mark your attendance now before we move forward. And then, finally, So all these neutrophils that come here, you told me their function was to kill the microorganism. So now they have killed the microorganism. Yes,
What's the function of red blood cells in the inflammation?
there is no function of them. They just, and because the permeability increases, they enter into the alveolus. They don't come for any help to the macrophages or something. So that's why macrophages take them as a extra person in the fight, so they just kill them too. Okay, now, the neutrophils are the macrophages which were present in the lungs. They did their job. They killed the microorganism. Now the pneumonia should finish or not? Because it was the microorganism that was causing inflammation. So now when they have done their job, what will happen to the inflammation? It will resolve. There will be resolution. Remember what I told you earlier? And the resolution occurs when the chemical mediators stop being released. No more vasodilatation, no increased vascular permeability. Will the exudate come out now into the alveoli? No, because the vascular permeability is gone. Why? Inflammation is stopping. Why is inflammation stopping? The neutrophils and the macrophages have killed the microorganism. And all those inflammatory cells which were present here, these inflammatory cells, they all, once they have done their job, they die with apoptosis. Okay? So this is the different stuff. Now, other causes of the lobar pneumonia. What was the main organism that caused lobar pneumonia?
Streptococcus pneumoniae.
Streptococcus pneumoniae. The other ones that can cause are Klebsiella pneumoniae, Haemophilus influenzae, and Staphylococcus aureus. They can also cause lobar pneumonia. Then we come to the bronchopneumonia. As I told you, Streptococcus pneumoniae can cause both of them, isn't it? But most of the time it will cause the lobar pneumonia. So Streptococcus pneumoniae is one microorganism that causes bronchopneumonia. Haemophilus influenza, Legionella, Pseudomonas, all these cause the bronchopneumonia. Here, the consolidation is not in the entire lobe, but is a patchy in the form of foci. Foci means focus, small areas of focus. And where are these areas? Surrounding the bronchioles. There is an inflammatory response, but this response is around the bronchioles, and as the inflammation intensifies, they enter directly into the alveolar spaces. Have a look at this. Can you see the white ones? This, these white patches are your bronchopneumonia. This person has a very severe bronchopneumonia in both. Here it's not about the field. Can you see one lobe? No. You cannot demarcate the lobe. The entire lung is filled with the patches of consolidation, which is bronchopneumonia. I wouldn't be asking this X-ray in the exam, so don't worry. Just to show you that the whole lung fields on the both sides. This person is in the ICU on the ventilator. Can you see the monitor's electrodes for the ECG? So it means he's really sick. He is in the ICU. Because with this kind of lungs, he cannot breathe on his own. So they have put them mechanical ventilation. Look at these patches of consolidation. Look at these blue white ones. Can you see that? Those white patches, they are actually the pale patches of consolidation. So this is your bronchopneumonia. Which type of pneumonia is this? Lobar, because the entire lobe is pale. There is consolidation. And which one is this? This is not lobar. This is bronchopneumonia. Can you see the patches, white patches?
Isn't that white?
This one is different. This is the pleura, the pleural membrane that surrounds the lungs. So just focus there. Okay. Now we come to the community-acquired atypical pneumonia. Yes.
Then the previous picture, what about the holes in the lobar?
The holes are the bronchioles. They are the bronchioles from where the air comes. Okay, now we come to the atypical pneumonia, the one which discussed now. The lobar pneumonia and the bronchopneumonia were the types of acute bacterial pneumonia, which is a typical pneumonia. Okay? Now we discuss atypical pneumonia. Here you have a febrile illness, you have the fever with it. But there is patchy inflammation, and that inflammation is mainly in the interalveolar septa, between the two alveoli, the wall that makes the septa, and in the lung interstitium. How the atypical is different from typical, have a look at this. First of all, in the typical or the acute bacterial pneumonia, there is a lot of alveolar exudate. Here, there is lack of alveolar exudate. The amount of exudate formed in the atypical pneumonia is less compared to the one that is formed in typical pneumonia. So once you have less alveolar exudate, there will be moderate amount of sputum. The sputum that the person throws out is moderate. In acute pneumonia, there is a lot of sputum production, so he's going to throw out a lot of sputum. Then, No physical finding and consolidation. I will tell you is.
Sputum is in saliva?
No, sputum is not saliva. Saliva is the water. Sputum is when you bring the secretions from your lungs and throw it out. Sputum. When you bring it from inside. Saliva is there in the mouth. So that's why when we take a culture for TB, we don't want saliva. We don't want spit. That is spit. Saliva. So if there is spit, no, it wouldn't work. We want from the lungs. We have to bring it from our respiratory tract. So, when you have more exudate, there will be more sputum. When you have less exudate in the airway spaces, there will be less sputum. So, in atypical pneumonia, there is moderate amount of sputum. In acute, typical pneumonia, there is a lot of sputum. Now, we come to the examination. I will tell you in the next lecture in the CBL, physical finding of consolidation. Physical, something to do with touching, something to do with physical. We do an examination called percussion. We do it like this. When we do it in the lung, the sound will be resonating. When it reaches the area where there is fluid, it becomes hard. So you know, it's a physical finding. You found it. Yes, there is fluid in the lung. Where? In this area, lower lobe, or in the middle lobe, wherever the sound changes. So when you have more exudate, definitely it will be easy for us to see. When there is less exudate, it is difficult to pick up on the physical examination. And finally, the inflammation is very acute in case of the acute pneumonia, and therefore there is a elevation of white cell count which is very high. Whereas in atypical pneumonia, it is not that high, moderate elevation of white cell count. So basically in atypical pneumonia, the inflammation of the lung tissue is not as strong as it is in acute bacterial pneumonia. What can cause atypical pneumonia? Like the typical acute bacterial pneumonia, especially lobar type, was caused by Streptococcus pneumoniae. It is mainly the Mycoplasma pneumoniae is the main microorganism that causes the atypical pneumonia, but your flu, the flu we get, it can cause atypical pneumonia, influenza A and B viruses, respiratory syncytial virus, RSV. It causes acute respiratory distress syndrome, ARDS, and can cause death in the children, small children. Adenovirus, rhinovirus, rubella, varicella, chlamydia, coxiella, all these are the microorganisms that cause atypical pneumonia. But what is the main microorganism that causes atypical pneumonia? Is your Mycoplasma pneumoniae, especially in the children and the young adults. Then we come to the nosocomial pneumonia, a person who has got who develops pneumonia while they stay in the hospital. So, what microorganisms are very common in the hospital that can lead to pneumonia are your Pseudomonas, Klebsiella, E. coli, Staphylococcus aureus. These are present in the hospital environment. But then, doctors are also present in the hospital environment. Why don't they get this pneumonia? Yes. Because they have a very competent immune system. They are healthy. If one of the doctors is not healthy, he has AIDS, or if the doctor is on an immunosuppressive therapy, he is at high risk of developing hospital-acquired pneumonia because he is in the same environment. Now, which patients are at higher risk of developing the nosocomial pneumonia are those who have severe underlying diseases, who are severely ill. Their immune system is already fighting some other condition and it is weakened. Immunosuppressed status, people who are using their medicines to suppress the immunity, they must be having a renal transplant or something, so they are on steroids to reduce the graft rejection, or they are on a chemotherapy, radiation therapy, or any other immunosuppressive therapy in autoimmune diseases. Those on prolonged antibiotic therapy, it means that they are fighting some infection for a long period of time and their immune cells are being utilized very frequently, and then prolonged antibiotic therapy can cause the resistance to the bacteria as well, and then that will not be able to cure easily. Then, in the hospital, the patients who have many invasive accesses. Invasive, going inside, cannulas, central venous line, going directly into the central vein, the nasogastric tube, the urinary catheter, any other tube like chest tube for the pneumothorax. All these things are invasive, and when you have these invasive things happening to you and you're staying in hospital for a long period of time, it increases your chance of developing pneumonia. Then finally the mechanical ventilation. You all know patients with COVID going onto the ventilator, isn't it? So a person, when he's on ventilator, for example, a person has an accident he had a head injury, he's unconscious, they put him on ventilator. Is he having a pneumonia? No, he came with a head injury. Now when he remains on the ventilator for a long period of time, he has a higher risk of developing the nosocomial pneumonia, which is because of these microorganisms. So these people are at higher risk. Now the aspiration pneumonia. Who asked the question about aspiration pneumonia? Yes, you asked. So we are discussing aspiration pneumonia now. Aspirate, to aspirate. When the gastric contents enter into the respiratory tract. You know the gastric contents are in the stomach, isn't it? So what is in the stomach mainly? Acid, hydrochloric acid. You put a drop of that acid on paper, the paper will burn. Stomach is made like it can tolerate that acid, not any other organ. And what else is in the stomach? You have the normal bacterial flora, isn't it? Beneficial bacteria. These are beneficial for digestion in the stomach, but if they enter the respiratory tract, that's not very beneficial. They will cause infection there. So when the contents from the stomach come up, when do we have that? When we vomit, isn't it? When they come up. And a strong person is going to vomit this all, making sure that it does not enter into your respiratory tract. You cough also with the vomit and stuff, so you are trying to make sure. Those patients who are debilitated, weak, old, they have the weak cough reflexes. They don't have a lot of power to throw out that. In them, the aspirate from the stomach, it comes up when they're vomiting. They cannot throw it out fully, and so they enter into the respiratory tract. Their cough reflex is also weak, so they cannot throw them out. What will happen? There will be damage to the lung tissue. Why? Because of two things. Number one, that acid, it is going to destroy the cells, direct chemical injury. And the second is your bacteria from the beneficial bacteria from the stomach, when they enter into your respiratory tract, that is where they will cause the pneumonia. Remember, lung abscess is the most common complication because there is a lot of dead necrotic tissue in the lung. So there will be collection of pus which is localized within the lung. I will show you in the next lecture how it is. This is the most common complication of aspiration. Now you tell me, this is the trachea. Right one, the left one. Which one is more in line with the trachea? Which bronchus, the right and the left bronchus, which bronchus is more in line with the trachea? Right one. So which lung is more vulnerable to get aspiration pneumonia? Right one. As soon as the acid contents come, they can very easily go like this. Yes, they can go into the other one as well. No one is saying they will never go there. But a lot of them will easily go to the right one, so the right one is going to be the effective most. And remember, lung abscess is an important complication of aspiration pneumonia. So which microorganism you can aspire? You remember the pneumococcus, streptococcus pneumoniae is an important component of the oral flora, which is present in the hair, in the throat. So that is the one. Haemophilus influenzae, Staph aureus, hospitalized patient. If you are hospitalized, it's the Pseudomonas. So remember, I'm just repeating, the ones the acute bacterial pneumonia is mainly caused by acute bacterial pneumonia. Streptococcus pneumoniae, very good. Then, you tell me what about the atypical pneumonia? Mycoplasma pneumoniae. What about the nosocomial pneumonia? Pseudomonas is the main microorganism. What about aspiration pneumonia? Again, Streptococcus pneumoniae is the main one. Okay? Now we go to chronic pneumonia. Chronic pneumonia is where there is consolidation in the alveoli, not that severe as an acute inflammation. The amount of exudate in acute inflammation is far more compared to the one in chronic inflammation. Yes, there will be exudate formation, but there will be very less. But in chronic inflammation, the problem is there will be chronic granulomatous inflammation, there will be granulomas there, and chronic inflammation is associated with the tissue injury, isn't it? So Mycobacterium tuberculosis is your main microorganism that causes chronic pneumonia. Fungi can cause that too. Usually it happens in immunocompetent people. The other pneumonias we're saying are mainly in people who have chronic diseases, immune deficiency, or immune suppression. Chronic pneumonia is something that can happen in an immunocompetent person, but why is that happening? The person has good immune system. Because this microorganism is not easy for the immune system to kill, as I told you earlier as well. So it leads to chronic inflammation, leading to chronic pneumonia. Then, it's the last slide now, the pneumonia and immunosuppressed host. It's very important. The most common example of immunosuppression is your AIDS. You studied that in microbiology SLE, isn't it? Microbiology CBL. You studied that, isn't it? So, how did the AIDS got discovered? In the United States, in a certain community, there were lots of pneumonia patients basically were coming to the doctors. And the doctors were surprised that they are all males. If it is spreading in the society, it should be in the females also. What's wrong with the males? And you know, this pneumonia should be happening in people who are old, who are sick, who have immune deficiencies. So many men, when they took the history, they found out they were all homosexuals. So when they tested them, they found this virus, the AIDS virus, they were all immunodeficient. Why they were immunodeficient? That led to the discovery of the AIDS, the human immunodeficiency virus. So it was mainly pneumonia. They are very common to have pneumonia that made this discovery, and one of the main reasons for the death in the AIDS patient is also pneumonia. So remember Pneumocystis carinii, this was that exact microorganism which was infecting those patients who led to the discovery of AIDS. Also your cytomegalovirus and Staphylococcus aureus, they are also those microorganisms which will be causing pneumonia and immunosuppressors. So when do you have immunosuppression? Number one, when you have immune deficiency. For example, you have AIDS. Second is immunosuppression. Yes, you have a competent immune system, but you are suppressing it intentionally to treat another disease. Or you have a transplant and you don't want the grafts to be rejected, so you put the immune system low by taking steroids and other medicines. So then that makes you more vulnerable to the pneumonia from these microorganisms. Radiation therapy of the tumors, certain tumors can also reduce the immunity. So all these are responsible for immunosuppression, and what are the main organisms that can cause pneumonia in immunosuppressed person? Cytomegalovirus, Pneumocystis carinii, and Staph aureus. Okay? Thank you very much. Next session will be CBR, same pneumonia, but we will see